Dr Elizabeth Raetz was also talking about two ways of looking at patients with acute lymphoblastic leukemia. Can you tell me what she was doing and what the importance of that was?
This was a huge study of 10,000 children with acute lymphoblastic leukemia who were treated on the Children's Oncology Group trials in the United States and Canada. And what this study showed was that by careful evaluation of this group of patients using both cytogenetics and molecular diagnostics for minimal residual disease, they were able to define a group of patients who, based on just purely clinical features, who were previously thought to be very high-risk patients, actually had very good outcomes based on chromosome analysis and minimal residual disease.
And a response rate came into this. What was that with the MRD?
The MRD, what minimal residual disease is the ability at a subclinical level to detect small numbers of cells that still represent the leukemic clone. And we know that patients who have low minimal residual disease or absent minimal residual disease after 4 weeks of treatment have a very good prognosis. Some of the patients in the study were classified by clinical features before they were treated as being very high risk. And yet, when the factors of minimal residual disease were used to reclassify these patients, it was found that there's a small percentage of these patients who would have been thought to be very poor risk patients with a high relapse risk actually had very responsive disease and had very good outcomes and would spare these patients then from getting intensified treatment.
Right, so that's an important step forward for clinicians to spare that toxicity.
That is a very important step forward.